In the conundrum of life, often in the pages of opportunities, I search for perceptions. First, I encountered the logical one. Then, did I encounter the magical one, the so called emotional one. Then, I came across the spiritual one, probably the most blissful one. Then, did I meet the largest one, the so called moral one or the ethical one. I sometimes wonder if that is the resultant of all these three, or is it a different dimension in itself? Let me know in the comment section.
So let's talk about something called as CSF rhinorrhea. So if you have CSF which is coming through your nose, then it will be called as CSF rhinorrhea. Usually it will have a history of head trauma or sometimes idiopathic also. Well, sometimes it comes as a clear fluid out of your nose, just like the nasal secretions, or sometimes tinged with blood. Talking about physiology, so this totally we have CSF of around 150 ml, so 90 to 150 ml, and the work of the CSF is to give this buffer around the brain and the spinal cord. It stops from it gives the cushioning effect, honestly, and it is produced by the choroid plexus and also from the lateral and the third and the fourth ventricles, and it is absorbed into the dural venous sinuses by the arachnoid villi, right? Now there is one important thing about the CSF is that when the CSF is getting drained into the blood, the villi actually shows a one way mechanism or one wall mechanism, which does not let the CSF to come out of the blood. So it is always a unidirectional process. In a day, you produce almost half a liter of CSF, so that would be somewhere around 20 ml per hour. Always remember, you always almost have 150 ml of CSF in the body, yet the pressure is also almost 150 mm of H2O. So the CSF pressure at lumbar puncture would be somewhere around 150 mm of H2O. That would be a number which you can remember. Remember, this 150 ml amount of CSF is cleared almost 3 to 5 times per day, and so usually when you're doing these activities of straining, like trying to compress your abdomen, then doing this heavy weight lifting, or putting excess strain in the during the stools, so this activities actually leads to the increased leak of CSF. Talking about etiology, you have trauma. So usually during surgeries such as the endoscopic sinus surgery or transsphenoidal hyposplenectomy or polypectomy, whenever they're trying to do that, or surgery to the skull base, they would injure it and cause trauma and cause leakage of it. Talking about inflammations, you have osteomyelitis, and this osteomyelitis kind of condition can erode the bone and dura itself, because of which these things can be the CSF can be lost, and then you have mucoceles of the sinuses or sinusal polyposis. Then you have neoplasms. Tumors could be benign or malignant. Then you have congenital lesions. So meningocele or meningoencephalitis becomes an important thing. Then you have something called as gliomas. These are also again tumors of the birth. Then you have idiopathic, something which happens rarely or something which happens spontaneously. Talking about sites of leakage, you have mainly 4 sites. One is the frontal, second is the ethmoidal, third is the sphenoidal, and fourth one is near the eustachian tube. If in case of a temporal bone fracture, so near the frontal sinus, ethmoidal sinus, sphenoid sinus, and the eustachian tube, this happens. If it is happening through the frontal sinus, it is because of the loss from the anterior cranial fossa, whereas from the when you're talking about the sphenoidal sinus, it's from the middle cranial fossa. How would you as a clinician differentiate between nasal secretions and CSF? Is that you'll ask for the first the content, matlab you'll ask him for the amount. So CSF fluid is produced like somewhere around in a higher content, and but nasal secretion, even if it is produced in higher content, it does not have any variations with position. But CSF fluid is the one thing which has variation in positions. If they were to lean forward, there will be more production, and if they won't be able to sniff it back, whereas nasal secretions you can sniff it back. If somebody did taste the CSF fluid, it would be very sweet. So the nasal secretions would be salty, of course. Talking about the CSF fluid sugar content, almost 30 mg per dl, which is basically high. but for a nasal secretion, the sugar content would be less than 10 mg per dl. This increased sugar content is the reason why they used to do glucose oxidase peroxidase method to, confirm the diagnosis of CSF leak. Beta 2 transferrin becomes the most sensitive and specific test for CSF fluid. If you were to test for beta 2 transferrin, this protein, you will get to know if it is CSF. So yeah, it becomes exclusive then, ruling out nasal secretions. Usually they'll give a history of nasal trauma. The CSF fluid people, the one with CSF fluid leak, they'll give a history of nasal surgery or injury. Whereas nasal secretion, it would be because of sneezing or stuffiness or itching or lacrimation, right? The nasal secretions would be slimy, whereas the CSF fluid would be, simply it will be thin and cleary and watery. How do you diagnose it? Like, see, some patients who get up early in the morning, take the route to the washroom, or probably go to their Surya Namaskara. These people, when they bend forward or they're straining too much excess, this fluid comes out of the nose, and you won't be able to, take it, absorb it back or sniff it back. So that becomes a problem. And another keyword here is reservoir sign, which is basically the fluid which is collected in the sinuses, particularly in the sphenoid, and it empties into the nose. It is always important for us to separate allergic rhinitis and rheumatoid rhinitis from CSF leak, because you can usually see, you can easily tell it based on mucus content. A double target sign becomes one important thing in or CNSF rhinorrhea, because there will be a peripheral arrow and there will be a central reddish discoloration. So yeah, this is a double target sign. Usually you do a nasal endoscope to localize the CSF leak, and to see if you also do a otoscopic examination to see if if there is anything involved there. Laboratory tests, yeah, specific and sensitive test is beta 2 transferrin, and even if you have very few drops about of CSF, it will be done. So you also have other thing called as beta trace protein. Beta trace protein is produced by the choroid plexus and also the meninges. So that also becomes a specific test, of course. So the specimen of the nasal discharge is tested for this protein. Right, this protein is tested for that. They would ask you this question, which would go like, what are the fluids which contain beta transferrin in body? There are only three fluids. One is CSF, the other one is the perilymph, and the aqueous humor. So the aqueous humor, the perilymph, and the CSF are the three things which contain beta 2 transferrin. Then you have glucose testing is something which used to be done earlier. We don't do it anymore. Localization of site, you do high resolution CT, frontal and sphenoid sinus. Whereas MRI, you do a T2 weight image. For intracranial pathology is suspected, and or if encephalopathy is seen, right? So you do an MRI. Then talking about intrathecal fluorescence study, well, this is nice. You can do this before the surgery or during the surgery. You basically tilt the person's head of 10 degrees Celsius, 10 degrees, and you inject the dye. If you look at it plainly, it will be yellow color. If you put a blue color filter, it will look fluorescent green basically, and you have to look for different places. Intranasal with an endoscope. You should look near the olfactory cleft, near the middle meatus, near the sphenoid sinus, just to check for that. You don't put a radioactive material. You don't do a radioactive material at all. CT cystonogram is one thing which used to be done earlier. Now it is not favored by many. Now talking about treatment, see, some conservative treatment is ask the patient to rest, ask the patient to decrease the height, give him some docosates or liquid paraffin to decrease his straining during stools, decrease the pressure of his stools somehow. Give him a carbonic anhydrase inhibitor like acetozolamide, because it basically decreases the CSF formation, and give him some antibiotics. Well, if you were to talk about a surgical approach, to do it, you could be doing it three ways. One is the intracranial, the neurosurgical intracranial approach, or the extradural approach, and the transnasal endoscopic approach, right? When you're doing with the extradural approach, you do an external ethmoidectomy for the cribriform plate, or sometimes you do an osteoplastic flap, which is for the frontal sinus leak. For a frontal sinus leak, you do an osteoplastic flap. Transnasal endoscopic approach is like you go to the anterocranial fossa, and in transplant, that becomes a very important thing. So endoscopy was a boon for ENT because of the same thing. Like you could easily find out pathologies which are extremely aggravating, yet easily approachable, accessible, and trying to repair it. So yeah, the transnasal endoscopic approach, if there is leak from the anterocranial fossa, you can easily repair it in the first attempt only. So what are the principles of repair? Is first you have to define where the problem is, where the bony defect is. Is it in the cribriform plate, or is it in the roof of the ethmoid, or is it the frontal sinus leak, or is it the sphenoid sinus leak, or is it the lateral lamina, right? Then you have to prepare for that place for the graft site. Then what you do is you underlay a graft. So you take up the fascia of the bone and you place a mucosa under that. You place a mucosa as a free graft or a pedicle flap. After that, if it is greater than 2 centimeter, you take a cartilaginous flap from the nasal septum or the ear auricle, and upon that you place the Surgicel or a gel foam, strengthen it, and give them some antibiotics, right? And also give them a nasal pack. Sometimes you take up fat from the abdomen or thigh to kind of place it there, and lumbar drain is necessary if the CSF pressure is very high. If the pressure is very high, you have to basically do a lumbar drain. And lastly, talking about, give them a set of antibiotics, oral antibiotics. Also you can give them systemic antibiotics. And lastly, remember that is CSF rhinorrhea.